Welcome to this deep dive into tram flap techniques. Today, our mission is straightforward. We are breaking down the critical clinical decision points between pedicled and free tram flaps to help you optimize outcomes in your breast reconstruction cases.
Right, we are looking at the realities of the operating room. We need to figure out exactly when to take muscle, when you are safe to scare it, and how to balance those overarching aesthetic goals with the very real risks of donor site morbidity.
Okay, let's unpack this. The transverse rectus abdominis myocutaneous flap, the tram flap. It's been a foundational pillar in reconstructive surgery for, over 30 years now?
Oh, absolutely.
I was looking back at the history, and Holmstrom initially described it as a free flap, but then Hartramp came along and really popularized the procedure.
He did. Hartramp independently conceived of its use as a pedicled abdominal island flap.
Oh.
He was drawing on some much earlier work by Esser, who was a pioneer in early tissue transfer. Esser was moving flaps based on their specific localized blood supply rather than just random tissue advancement.
What's incredible to me is the sheer leap of faith that must have been back then.
Totally.
To theorize that you could take the lower abdominal skin and fat and transfer it all the way up to the chest to create a breast mound while relying solely on the circulation from the rectus abdominis muscle.
And doing this without microvascular anastomosis.
Right. It was revolutionary.
His early success with a patient who had experienced a devastating implant failure after a radical mastectomy, it completely ushered in a new era of breast reconstruction. You might ask why it remains so relevant today, decades later, when we have so many other options.
The unmatched clinical value it provides is still the answer.
Exactly. The tram flap gives you a massive volume of autologous skin and fat. That is an absolute game changer.
Especially when you were dealing with delayed reconstructions. Imagine a patient coming into your clinic following a mastectomy, and they've had a course of post-mastectomy radiation. The chest wall tissue is often incredibly tight, contracted, damaged.
In those specific cases, the requirements for achieving any kind of symmetry with the opposite breast don't just depend on adding volume underneath the skin. You need extensive amounts of actual skin replacement.
You cannot just place a device under tight, irradiated skin and expect a great result.
You really can't. The tram flap delivers both the volume and the healthy, pliable skin envelope you desperately need.
So we know why we use it. We know the history. How do we break down the anatomy for someone scaring down a complex reconstruction? We're essentially looking at two distinct blood supply systems for these lower abdominal flaps.
Right. For the pedicled TRAM, you are relying entirely on the superior epigastric system. Those vessels travel down and arborize, meaning they branch out right within the rectus muscle. They act as the primary conduit to provide perfusion to all those lower abdominal tissues you're removing.
And then if we look at the microvascular options, the free flaps, you shift your focus completely away from the top and look down at the inferior systems.
Exactly that. You utilize the deep inferior epigastric system for the free TRAM and the DP flaps. Or you look even more superficial and use the superficial inferior epigastric system for the SI-EVAP flap.
These inferior systems are generally the dominant blood supply to the lower abdominal skin and fat, which is why they are so appealing for microvascular transfer.
This brings us to a major clinical decision point: muscle sacrifice.
Right, I know it's a spectrum and there are specific classifications. Can you walk us through the muscle-sparing levels?
Sure. We group these into muscle-sparing, or MS, levels. MS0 flaps make use of the entire rectus muscle. You take it all.
Got it.
Then you have MS1 and MS2 flaps, which sacrifice progressively decreasing amounts of that rectus muscle. You preserve some lateral or medial segments to maintain core function.
And then we get to MS3. That is the DIEP flap, the deep inferior epigastric perforator flap. This one gets a lot of attention because it takes absolutely zero muscle, right?
It takes zero muscle, but we have to be very precise here. It still involves dissection through the muscle. You're tracking those tiny perforators down to the main source vessels.
Which means you are causing concomitant injury to a portion of the rectus muscle and its intercostal innervation just by doing the dissection.
Exactly. So even though you aren't harvesting the muscle, you are still traumatizing it.
Is there an option that avoids the muscle entirely?
That would be the MS4, the SEA flap. That technique requires zero muscular dissection and zero muscle sacrifice because you are using the superficial system. You don't even open the fascia.
If we connect this to the bigger picture, it sounds like a very direct trade-off for the patient. Reduced muscular dissection and sacrifice lead to decreased abdominal wall complications and much better long-term abdominal wall strength.
It is a trade-off, but here is the flip side that often surprises people. DIEP patients, The ones where you spare the muscle entirely actually face higher flap-related complications than the non-muscle-sparing free TRAM patients, the MS0 group.
Wait, why is that? If you are preserving their core strength, why is the breast reconstruction itself at higher risk?
Because you have a drastically reduced number of perforators supplying those transferred tissues. In an MS0, you are taking a huge block of muscle and all the muscles running through it. In a DIP, you might be relying on one or two isolated perforators.
You are literally trading a stronger core for a more tenuous blood supply.
Exactly. That is quite the tightrope to walk in the OR. Let's pivot to clinical indications and patient selection. These flaps are incredibly versatile for either immediate or delayed reconstruction.
But clinically, they shine in a very specific scenario.
They are absolutely ideal for matching a ptotic. Remember, that's pronounced ptosis, opposite breast.
A ptotic breast has a natural drape, a specific teardrop shape that is heavily influenced by gravity.
Breast reconstruction utilizing tissues of the lower abdomen generally permits a much softer, more natural reconstruction that mimics that exact drape far better than any implant could.
Plus, that autologous tissue tends to age naturally alongside the native opposite breast. A device reconstruction just sits there high on the chest wall.
Right, while the patient's native tissue changes and settles over time, leading to severe asymmetry down the road.
However, this potential improvement in softness and symmetry comes at a very real cost. You are looking at a much longer operative time, a significantly longer hospital stay.
And of course, an abdominal donor site that carries the risk of weakness, bulge, or full-blown hernia.
Which brings up a massive pitfall in the clinic: managing patient expectations. A patient hears we are taking tissue from their abdomen, and their mind instantly goes to a cosmetic tummy tuck.
They think they're getting a two-for-one deal.
Exactly. You have to nip that expectation in the bud immediately.
While both procedures might enhance the appearance of the lower abdomen by removing extra skin and fat, they are structurally and aesthetically quite different.
Remind your patient during that very first consultation that the abdominal scar in a tram flap is positioned higher than what would be considered aesthetically ideal for a cosmetic tummy tuck.
You definitely don't want a patient waking up and being completely furious about a scar placement that was medically necessary just to ensure the flap survived.
Those differences have to be clearly explained preoperatively. Unrealistic expectations are the enemy of a successful reconstructive outcome.
So imagine you are in the OR, you've made your incision, and you are evaluating the anatomy. How do you choose between the different flap options on the table?
There is an incredibly practical tool for this Nahabedian's decision-making algorithm.
It is a brilliant, straightforward algorithm for deciding between a DIEP and a free TRAM in real time. You are looking at the perforators. If you need a flap that is less than 750 cc's in volume, and you can identify a perforator that is at least 1.5 millimeters in diameter,
A DIEP flap can be safely selected. You have enough flow for that specific volume.
but what if the patient requires a much larger volume flap? Or you are searching with your loops and the perforators are simply inadequate, meaning they're smaller than 1.5 millimeters.
In those scenarios, you have to pivot. Those patients are much better candidates for a muscle-sparing free tram flap.
Right. You take a little muscle, an MS1 or MS2, to ensure you capture enough vessels to reliably support the larger tissue mass.
What about patient risk profiles? Because this is where conventional wisdom seems to get flipped completely on its head. Say you have a patient in a high-risk category. Maybe they have a history of heavy cigarette use, defined as greater than 10 pack years.
Or they are significantly overweight or obese.
A lot of surgeons might instinctually want to avoid a complex microsurgery for those patients.
It is counterintuitive, but actually those high-risk patients are vastly more suitable for a free TRAM rather than a Pedicled TRAM reconstruction.
Really, why subject a high-risk patient to a longer, more complex microvascular case?
It all comes down to the blood supply. The improved flap perfusion you get from that dominant inferior epigastric system is crucial for smokers and obese patients whose microvasculature is already compromised.
Combine that with reduced rectus muscle sacrifice compared to a Pedicled TRAM, and you have a safer operation for their specific risk profile.
That makes sense. And that is particularly true for patients undergoing bilateral reconstruction, where you really can't afford a massive hit to their core strength.
Yes. Now, for normal risk patients, those without significant comorbidity, a normal BMI, and no heavy smoking history, there is essentially no difference in the incidence of flap or abdominal complications.
Whether you use a unipedicle, a bilateral single pedicle, a double pedicle, or perform a free tram. The complication rates for healthy patients are practically identical.
So we've established the pedicled flap as the reliable workhorse despite all the shiny new microvascular options out there.
The pedicled TRAM is still the preferred technique for most surgeons performing autologous reconstruction.
What keeps it at the top of the list?
Advocates for the pedicled TRAM point to a very compelling, very practical list of benefits. Its absolute reliability, its predictable blood supply, the ease and speed of harvest, its proven safety in appropriately selected patients.
And, quite simply, you avoid any requirement for advanced microvascular skills and delicate instrumentation. Not every hospital has a microsurgery team on standby.
In real life, the relative simplicity of harvesting the pedicled flap buys you something invaluable in the OR time.
It affords the surgeon much more time to focus on the intricate insetting and shaping of the breast mound, which can lead directly to superior aesthetic outcomes.
And the widespread popularity of skin-sparing mastectomies over the last 2 decades has made that shaping task considerably easier.
It gives the reconstructive surgeon a fantastic native skin envelope to fill, rather than having to reconstruct the entire cutaneous surface.
Let's talk about the actual harvest. How do you approach it?
The flap is based on the superior epigastric vessels. Here's the key point. Use a split muscle technique. You preserve the medial and lateral segments of the rectus muscle in the abdomen, taking only the central portion containing the vessels.
I know there is some debate there. If you ask 5 reconstructive surgeons, you'll probably get a debate on whether a whole muscle approach is actually superior to the split muscle.
Oh, absolutely. The debate centers on the vascular network. Some staunchly defend a whole muscle approach because a muscle-sparing technique might exclude some of the normal connections, the choke vessels, between the superior and inferior epigastric systems.
Excluding those could potentially decrease overall flap perfusion.
But the primary undeniable benefit of the split muscle technique is that it drastically reduces the incidence of severe abdominal contour deformities postoperatively.
And having those muscle remnants permits a much more secure, immediate fascial closure. How do you handle that closure?
When you go to close the fascia, use a continuous, non-absorbable suture. That is the gold standard for preventing dehiscence.
Here's a critical common pitfall I want to highlight during that closure. It's the classic OR trap down in the lower abdomen.
Yes, extreme care must be taken to ensure that the internal oblique fascia is actually included in the repair. Down in the lower abdomen, below the arcuate line, the fascial anatomy changes.
The internal oblique fascia tends to sneakily retract underneath the external oblique fascia. It can be incredibly easily missed.
So you are closing up, you think you have a solid bite of fascia, but you've only grabbed the external oblique.
If the internal oblique is inadvertently excluded from your suture line, you will almost certainly see a postoperative abdominal bulge or a frank hernia as a result.
You have to actively hunt for it and ensure it's incorporated in every single bite.
Do you routinely use mesh to reinforce that area?
Use mesh as an onlay only after you have achieved the best possible primary fascial closure. You don't use it to bridge a gap if you can avoid it.
The indications for mesh are specific excessive tension on the primary repair, or if the fascia actively tears at closure, or if it just appears visibly thin and weak.
But you rarely require mesh following a standard single pedicled TRAM flap.
It is rare. It is required much more frequently in patients undergoing bilateral or double pedicled TRAM flaps, where you have simply taken twice as much fascial tissue and the defect is massive.
And regarding routing the pedicle up to the chest, you can base it on an ipsilateral or contralateral pedicle relative to the mastectomy defect.
Favor the ipsilateral pedicle whenever possible. It is chosen most often because routing it straight up significantly reduces the unnatural bulk in the epigastrium.
Tunneling it across the midline creates a very noticeable bulge right between the breasts.
Surgery is constantly evolving. What drove the push toward the microvascular side, the free tram, if the pedicled flap is so reliable?
It really represents an immense refinement in technique. Surgeons sought to optimize flap viability while simultaneously minimizing that donor site morbidity we just talked about.
That drive to do better is what led to the popularity of the highly muscle-sparing free flaps like the MS-1, MS-2, and eventually the DIEP.
By utilizing those techniques, you get the distinct advantages of reduced abdominal dissection, way less muscle sacrifice, and far less attendant core weakness for the patient.
Plus, you get enhanced flap vascularity from those dominant inferior vessels. And from a purely aesthetic standpoint, you get an incredible ease of flap inset.
The biggest advantage, You completely avoid any disturbance to the inframammary fold.
That fold is so crucial for the final shape of the breast. With a pedicled flap, you literally have to tunnel the tissue up the abdominal wall and force it over the inframammary fold.
Which can blur or distort that crisp lower boundary.
With a free flap, there is no tunneling. You sever the vessels, carry the tissue to the chest, and transfer it directly.
Precisely. The flap is based entirely on the deep inferior epigastric vessels. A small segment of muscle and fascia from the lower abdomen is utilized, which vastly simplifies the abdominal closure.
When you bring that free flap up to the chest, you need recipient vessels to plug it into. You typically use either the thoracodorsal vessels in the axilla or the internal mammary vessels near the sternum. How do you choose?
It used to depend heavily on the ease of harvest. But in real life today, there has been a major surgical shift. As more breast surgeons move away from formal radical axillary dissections and towards sentinel node biopsies, the axilla is often untouched.
Because of that, the internal mammary vessels have surged in popularity as the recipient vessels of choice.
Using the internal mammary vessels permits a much more central, natural positioning of the flap. You completely avoid needing an awkward axillary extension of your skin-sparing incision.
And you keep out of the axilla entirely if the general surgeon hasn't operated there.
However, this raises an important question and a very real clinical trade-off. By using the left internal mammary artery, the lima, you are permanently sacrificing a vessel that the patient might desperately need later in life for coronary artery bypass grafting, or CABG.
Cardiothoracic surgeons rely on that vessel. That potential future need has to be factored into your decision, especially in patients with a family history of heart disease.
We also have to address the harsh reality of complications with microsurgery. The free TRAM demands highly specialized microvascular skills and significantly longer operative times under anesthesia.
And its main unavoidable disadvantage is the significantly higher incidence of total flap failure when compared directly with the pedicled TRAM.
That is a terrifying outcome. With a pedicled TRAM, a total 100% loss is virtually non-existent because it's still attached to its source.
With a free flap, if the anastomosis thromboses and you can't salvage it, you lose the entire reconstruction.
Decision-making when selecting a technique must take into consideration your own personal documented success rate with free flat breast reconstruction.
Before you commit a patient to a procedure with a potentially higher rate of complete catastrophic failure, you have to know your own numbers honestly.
Let's evaluate the overall management of morbidity and flap viability. The debate over abdominal bulge, hernia, and core weakness has been raging since the TRAM was first introduced.
And it continues today in every major plastic surgery conference. There is a very direct, unavoidable relationship between harvesting more muscle to get more perforators and a safer blood supply and improved flap perfusion.
But that safety net comes at the direct cost of diminished functional strength and a significantly increased abdominal bulge and hernia risk.
There's a great practical measure for this, the ability to perform a sit-up post-operatively.
That ability is directly dependent on the amount of muscle harvested. Patients undergoing a free TRAM, or DIEP, are much more likely to preserve their unassisted sit-up ability compared to those with a pedicled TRAM.
But we should note, even despite that finding, harvesting a pedicled TRAM rarely affects normal activities of daily living.
Most patients generally do return to their preoperative athletic pursuits over time, even if they struggle with a strict sit-up.
Now, looking at flap morbidity on the chest, fat necrosis, partial flap loss, and total flap loss can absolutely occur with either technique.
We've established that patients who are heavy past smokers, actively smoking at the time of surgery, or are overweight face an increased risk for these complications.
So how do you mitigate that risk in the OR?
In general, increasing the numbers of perforators included with the flap drastically reduces the incidence of fat necrosis and partial or complete flap loss.
So if you have patients requiring larger flaps who smoke or are obese, they are actually much better candidates for less muscle conservation.
Less muscle conservation, meaning you actually take more muscle. You sacrifice the core strength to grab that robust blood supply to ensure the flap actually survives the transfer.
You prioritize the survival of the tissue over the abdominal wall function. Finally, there is a concept of surgical delay.
For high-risk categories, surgical delay where you ligate some vessels weeks before the main surgery has been suggested to improve flap vascularity prior to the main transfer.
The experimental data does suggest that blood flow is significantly enhanced in the superior epigastric vessels after a delay procedure.
Right. The experimental models show that. But clinically, Looking at actual patient outcomes, studies have not consistently proven that a delay procedure actually reduces the incidence of flap complications in high-risk patients.
It remains a heavily debated extrasurgical step that subjects the patient to another trip to the OR without guaranteed benefit.
We have covered a massive amount of ground today, from the history to the microscopic vessels. Let's do a quick recap of the clinical takeaways for everyone heading into the OR.
First, always match the flap to the perforator anatomy and your specific patient's risk factors. Remember Nahabedian's algorithm. If you need a large volume but have small perforators under 1.5 millimeters, you need to include muscle.
Second, mind the internal oblique fascia during your abdominal closure. Actively look for it. Grab it with every single bite to prevent a devastating postoperative hernia.
And third, always balance the aesthetic goals of the breast reconstruction with the functional preservation of the donor site. It is always a trade-off.
Here is a final provocative thought for you to consider on your next case. As microvascular techniques continue to evolve rapidly and purely perforator flaps like the DIEP become even more refined and commonplace, will muscle-sacrificing techniques eventually become entirely obsolete in breast reconstruction? Or will the rock-solid, predictable reliability of the pedicled flap always hold a vital place in our surgical arsenal? Something to think about. Thanks for listening.